I'll start off just by telling you a little bit about my background and then a little bit about my organization, Cortica, and then we'll dive deep into some topics related to autism and neurodevelopment and brain function, brain development. And then I'd like to close with a client vignette. So to talk about a patient of mine. So I am a pediatric neurologist and a board certified behavior analyst, a BCBA. So I have kind of dual professions, both in medicine and also behavior analysis, ABA. And, my initial inspiration to that kind of launched my career in this field was back when I was a high school student. I grew up in Toledo, Ohio, and I had an incredible experience volunteering at a summer camp for children with autism, intellectual disabilities, cerebral palsy, spina bifida, so a wide range of neurological differences. And the experience of being a high school student volunteer in that setting was so inspiring. And I just really saw the joy and the beauty of neurodivergence. And that kind of set me off on the career that I've had since then. I was an undergraduate at Harvard studying history of science, especially the history of medicine. I was very interested in kind of how medicine has changed over time and also the social and cultural influences on how we practice medicine. I went to medical school at Harvard as well. Between undergrad and medical school, I spent 2 years at Oxford on a Rhodes Scholarship, and there I had the opportunity to dive deeper into actually business school. So a lot of what I learned there in business has now helped with the establishment of my organization, Cortica. I did my pediatrics training at Mass General Hospital in Boston, and then my pediatric neurology training at the University of California, San Francisco. And then after that, I was a researcher at Columbia University for a number of years and also on their faculty, and focused on studying using brain imaging to better understand structural and physiological differences in the brain in autism, and also metabolic differences. So part of my area of specialization is mitochondrial dysfunction in autism. And I was at Columbia, the co-director of their multidisciplinary autism program that did both research and also multidisciplinary services. And so what I saw at the different academic institutions where I worked in terms of what they did well, with interdisciplinary care and research, kind of has been the inspiration behind establishing Cortica, which is the clinic that I founded about 10 years ago and which now has clinics across the country. But really what Cortica was intended to help solve is this problem here. So the current landscape of fragmented care for neurodevelopment, where families often find themselves in a very, very confusing landscape. They're receiving recommendations from their physicians, from local sort of government agencies. In California, it happens to be called the Regional Center System. Schools, they're navigating all of these complex institutions, health insurance, hospital, medical settings, and trying to bring together these kind of multifaceted care programs that we know are so important for supporting child development. In the meantime, they don't really know what information that they're getting is actually the best, the gold standard. What will it cost them? Often is unclear. And how are they going to navigate this really confusing landscape? And so treatment for autism has really been hindered by just the construct, right, of how care is set up in our communities. And so what we offer at Cortica is a whole child care model. So we're bringing together medical care, behavioral services, developmental therapies, mental health support, and we have a team of physicians, nurse practitioners, behavior specialists, speech, occupational therapy, physical therapy, music therapy specialists, mental health professionals, and then an administrative team to support all of the complexities around enrollment and navigating care over time, and scheduling, and getting payment reimbursement from health insurance. And so we now have a team of over 2,000 that are part of Cortica. 90% of those are clinicians. And we have 21 clinics around the country. So these are the states that we're in currently, California, Illinois, Texas, New Jersey, Arizona, Massachusetts, Connecticut, and North Carolina. And these are the cities that we're in each of the states. And really our hope is to continue to grow so that we can provide access to the high standard of care for autism for as many families as possible in the US. And actually our first international clinic is being set up in the coming months in Saudi Arabia. So we have a really exciting partnership with a group there that is helping to bring Cortica into that country. I'll also mention, before I get into some of the autism and neurodevelopment and some of the science and research, that everything I'm going to talk about today and everything that Cortica does is captured in this book that I published in April of this year, really to be a resource for whole child autism care, primarily for families, but also for professionals. And so I wrote this to be sort of a roadmap for caregivers to encompass all of the key parts of autism care from my point of view. So things like medical testing, nutritional and pharmacological therapies, device-based therapies, which are sometimes called neuromodulation. This is a very new and innovative area of autism care that's very exciting. And then, of course, mental health, behavioral, and developmental strategies, which are so important for learning. How to understand each child's unique neurodevelopmental profile and support every aspect of a child's health. And then how to understand and then nurture the development of brain networks in each of the major domains of brain development, which are sensory, motor, cognitive, language, social, and emotional. How to create optimal learning experiences in all settings: home, therapy sessions, school, community. And then finally, and most importantly, how to nurture a child's intelligence, abilities, and gifts using the principles of neurodiversity. Because we know autism, even though it comes with challenges, it comes with many different types of intelligence, abilities, and gifts and strengths. And the more we can recognize and nurture those, the more opportunities there are for autistic individuals. So I really very firmly believe that everything that we do at Cortica and everything I do is in service of the neurodiversity movement. And so that's really, in my view, why we exist and why I do the work that I do. So in our time together, I'm going to cover kind of these three main questions. What is autism? What factors increase the likelihood of autism? And what are the differences in brain development in autism? And in that part, we'll also cover some of the differences in the rest of the body too. And then I'll close with a client vignette. And as I'm going, please feel free to put any questions in the chat, and then I'll pause and leave time for the questions. So just a few definitions to start off with. And these are, I feel are very important. And so just want to kind of establish what each of these terms means. So neurodevelopment, of course, means the formation of neural networks. That's part of child development, and it's the basis for all human behavior and experience. And so therefore, it's just infinitely fascinating. The term neurodiversity refers to the natural neurological differences that exist in all people that lead us to experience and interact with the world in different ways. And the word neurodiversity was coined by the sociologist Judy Singer, who herself identifies as autistic. And she says it is the limitless variability of human cognition and the uniqueness of each human mind. The idea of autism acceptance is also incredibly important. And the Autistic Self-Advocacy Network has said, autism acceptance means embracing autism as a natural part of human diversity and accepting autistic people as members of a neurological minority group who are entitled to the same rights as everyone else. And what's very exciting is that research has advanced to a point where we now know how to give access to these same rights, to communication, to pursue one's interests and strengths. So that is a very important concept. And then finally, the terms ableism and anti-ableism are also important to understand. And ableism means the beliefs and practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities, and often rests on the assumption that disabled people need to be fixed in one form or the other. And so to adopt an anti-ableist view means to be a proponent of the strategies, theories, actions, and practices that challenge and counter ableisms, inequalities, prejudices, and discrimination. And so that is really core to the neurodiversity movement is anti-ableism. And so that is really very much the focus of the work that I do. And even though much of what I'll be talking about is sort of from a professional's perspective, a clinician's perspective, I and we at Cortica are always very much trying to incorporate the community's perspective, meaning the community of autistic individuals and their priorities, their values, and what some of these really exciting and growing autistic self-advocacy groups are saying. So it's very important for us as professionals to be listening and to be learning. And so really, in my view, is a balancing of the clinical professional perspective and the community perspective. And part of that is using our language and our terms with care and understanding what they imply. And so it's come about that we now recognize that as professionals, there are some potentially ableist terms that we use very commonly. And there are alternatives that are preferred. And so I very much try to use what you see here in the column of suggested alternatives, including identity first language, so saying autistic person rather than person with autism. I do sometimes use both interchangeably, but the idea behind identity first language is that there is a desire to view autism as a part of one's identity that is of value and not as a disorder that someone has. And so that is the rationale behind a more recent shift towards identity first language from person first language, which historically was what many of us as professionals were trained in. Okay, so let's talk a little bit about what autism is. The first thing to know is that definitions of autism have changed a lot over time. They will likely continue to change into the future as research advances and our knowledge continues to grow. But it was first in the 1940s that autism appeared in the medical research literature. It was described by two physicians, Hans Asperger and Leo Kanner. Through the 1950s to 70s, so much was just not understood about autism. And there were a lot of theories, including some very harmful theories that were espoused by the healthcare profession, by physicians, by psychologists, by therapists. One of them was the theory of what they called refrigerator mothers. So the idea was that autism was caused by poor parenting. And so mothers in particular were blamed. It was thought that a mothering style that was aloof, distant, or cold was the reason for a child's autism. There have been books now and documentary films that talk about the great harm that was done by the medical profession in espousing those kinds of ideas. And so for me, it's just always important that we remember those aspects of our history so that we are trying really not to make mistakes like that cause so much harm as we go forward into the future. In 1980 was when the Diagnostic and Statistical Manual of Mental Disorders, the DSM, first included autism as a formal medical diagnosis. So this is a publication of the American Psychiatric Association that really sort of defines for the field of healthcare what diagnoses are in kind of the realm of psychology and psychiatry. And we'll talk in a moment about the current version of the DSM and how it defines autism. In 1999 was when Judy Singer wrote her thesis and ultimately published a book on neurodiversity, and it kind of launched the neurodiversity movement. And then into the 2000s, there's just been wonderful evolution and the rise of autism self-advocacy organizations to really bring autistic voices to the forefront and to shape our understanding of autism, and also as professionals and healthcare providers, the services that we offer in a really positive way. So the current version of the DSM defines autism according to two main categories. One is differences in social communication and social interaction. And the other category relates to differences in behavioral flexibility. And so the DSM refers to these as restricted, repetitive patterns of behavior, interests, or activities. And then a part of the autism diagnosis is also specifying level of support needed by an individual. So level 1 is sort of a more mild degree of support, whereas level 3 is the most substantial level of support needed. The DSM has limitations. It frames diagnoses in a very negative, deficit-oriented, problem-centered way. But some really more empowering and positive messages have come out from autistic self-advocacy organizations like the ASAN that says there's no one way to be autistic. Some people can speak, some autistic people need to communicate in other ways. Some have intellectual disabilities and some don't. Some need a lot of help in their day-to-day lives and some only need a little help. But all of these people are autistic. There's no right or wrong way to be autistic. There are some common features, but there's so much variability. And all autistic individuals experience autism differently, but contribute to the world in meaningful ways and deserve understanding and acceptance. And so it's really kind of balancing what is somewhat a more deficit-oriented view in healthcare with something that's more, much more abilities-oriented and life-affirming. And now what we understand about autism too is that, yes, there are some core features here that relate to differences in socialization and behavioral flexibility, but there are what are called co-occurring features or co-occurring conditions that, and these are all features that occur more often with autism than in neurotypical populations. And so there are some medical co-occurring conditions, developmental, mental health, and behavioral. And these are extremely common with about 90% of children, autistic children, having at least one co-occurring condition, and 50% having 4 or more. And often it is the co-occurring condition that affects a child's well-being, development, and quality of life, even more than the core features of autism itself. And so it's very important that a diagnosis of autism is not viewed as kind of the final answer. Really, it's just a starting point, and a lot more investigation needs to be done for co-occurring conditions so that appropriate support can be provided. One of the biggest mistakes in our field is to label co-occurring conditions and dismiss them as saying, as quote unquote, part of autism. So for example, self-injurious behavior often is kind of mislabeled as being part of autism, but really it could have a number of different underlying root causes. And each of these would need to be better understood because it would lead down kind of a different path of treatment and support. We know that sources of pain in the body, headache, abdominal pain, allergies, dental pain are very often a precipitant of self-injurious behavior. We know differences in sensory processing can also be. So a person who might have hypersensitivity to certain auditory or visual stimuli, that might lead to a state of increased stress, so a greater stress response that could contribute to self-injurious behavior. We know that differences in the state of stress are very common. So this is sometimes called dysfunction of the autonomic nervous system. So the balance between the sympathetic and parasympathetic systems, or that fight or flight response, the stress response versus the relaxation response or rest and digest response. And that autism very often comes with chronic hyperactivation of the sympathetic nervous system. And that can contribute to self-injury. And there are steps we can take to improve it. So again, it's so important that we're thinking about co-occurring features and conditions and providing support for them. Now, I'm going to take you through a few slides now to think about autism. What I can sometimes call this zooming in and zooming out. So really, it's like all the different levels at which we can think about neurological development, because at each level, then it prompts us to offer some specific support. So to have a whole child comprehensive approach to autism means understanding neurodevelopment at each of these different levels so that we can offer support at each level. So the first level is really microscopic, right? So we're zooming in, we're thinking about the neuron. We know the brain is made of neurons, and we know that neurons have electrical and chemical properties. So information travels, along a neuron as an electrical signal, between neurons at the synapse as a chemical signal. And there's actually so much that can be done through tests like EEG, or even MEG, magnetoencephalogram, so ways to measure the brain's electrical activity. And there are also blood and other types of tests that can tell us a lot about a person's the chemical environment of the brain. And then you can make interventions like dietary changes, nutritional supplements, medications, or device neuromodulation therapies to help improve the electrical and chemical properties of the brain. We zoom out a little bit, we know that the brain makes up really the brain networks, right? So brain networks are what underlie all developmental skills. And there's so much that can be done to understand the function of those brain networks, and then to create opportunities, learning opportunities through various types of therapies that can help to form new brain networks to advance developmental skills. That is very much the focus of developmental therapies like occupational therapy, speech-language therapy, music therapy, physical therapy. Now, if you zoom out a little bit further, we know, of course, that the brain is connected and embedded with the rest of the body. And so the function of all other body systems influences brain function and development. So the health of the gastrointestinal system, the immune system, general metabolism, hormones, all of that has a profound influence on child development. And so attention needs to be paid to those other systems so that they can be supported. And then finally, if we zoom out even further, we know, of course, that each child is embedded within an environment, a context of people and experiences in school, in the community, at home. And all of those experiences profoundly influence brain development and all of those relationships. So attention there is so crucial, and is one of the really areas of specialization of behavior therapy, because behavior therapy is really looking at how environments can be modified to enhance learning opportunities and brain development. Okay, so that's my kind of, in a nutshell, how I view autism. Now, what do we know about what factors increase the likelihood of autism? Okay, and here's a diagram that I'll be walking through with you for the remainder of the presentation today. And we're going to start to fill in each of these boxes. But we're going to start here in the upper left corner and look a little bit at the genetic and environmental factors that increase the likelihood of autism. Okay. So in the genetic category, we know, of course, that that our genetic information lives inside of cells in the nucleus as chromosomes. And there are over 100 different ways that research has now identified that there could be alterations in a person's genetic information that might increase the likelihood of autism. So for example, a person could have an extra or missing chromosome. A person could have an extra or missing piece of a chromosome. Those are called chromosomal duplications or deletions. A person could have a change in a single nucleotide in a gene, which could then go on to alter brain development in a way that would increase the likelihood of autism. What's really fascinating is that from thousands and thousands of research studies, we now know that it's not typically one genetic alteration or genetic variant that underlies autism, but rather many. So any given individual typically has many different genetic variants that come together and interact in complex ways that then influence brain development to increase the likelihood of autism. And there are tests for these. So tests like chromosomal microarray analysis, whole exome sequencing and whole genome sequencing, and a variety of other genetic tests. So genetic testing is one of the first things that should be done when a child is diagnosed with autism. Those genetic findings can tell us a lot about metabolism, biochemistry, electrical differences that might be happening in the brain, because genes have downstream implications, right, for physiology. And so sometimes parents will ask me, well, why do genetic testing if we can't directly change my child's genes? Well, the genetic testing gives us information about things that we can then do to help support. There are also non-genetic factors that increase the likelihood of autism. There are certain environmental exposures, certain toxins. So there are some medications that are well known that if a fetus is exposed to them during pregnancy, can influence the brain in ways to lead to autism. There are actually also, unfortunately, dozens of different industrial chemicals that are now widespread in our environment that research studies have shown have adverse effects on the developing brain. So that, of course, is a huge public health concern and requires a lot of attention. Certain infections can affect fetal development, as can certain types of brain injury. And then there are some parental factors, like older parental age over 40, and some maternal health factors, like autoimmune conditions, metabolic conditions, that can also increase the likelihood of autism. And again, it's not usually just one non-genetic factor. It's usually many non-genetic factors and many genetic factors that interact in complex ways that then lead to autism. Understanding all of these can help. So it's all about, it can kind of help deepen our understanding of a child's unique biology and then inform how we support them. Okay, so those genetic and environmental factors influence brain development, and we actually know a lot now about how they influence brain development. And one of the ways is that it alters brain connectivity, and so therefore it influences information processing. And one of the findings that has come out of brain imaging research studies is that there seems to be an increase in what we call short-range connections. So brain networks that connect parts of the brain that are close together, those seem to be enhanced. And that leads to what in neuropsychology or cognitive neuroscience is referred to as enhanced local processing. And we'll talk in a moment about what that looks like. There's also a reduction of long-range connections. So the brain networks that connect parts of the brain that are farther apart, especially between the prefrontal cortex, so the very frontal areas, regions of the cortex, to other parts of the brain that are farther away, those seem to be reduced, which leads to what's called reduced global processing. So this altered balance of brain connectivity then leads to a number of differences in the brain and how the brain is functioning. And so one of these is differences in sensory processing. And here there's just a nice video clip of Temple Grandin, who is a prolific autistic author and a professor of animal sciences. So she'll talk in this video a little bit about some of the differences in sensory processing in autism.
People have got to recognize the sensory issues, that you have an autism, Asperger, ADHD, dyslexia, many different diagnoses. I have sound sensitivity. When the school bell went off, it hurt my ears like a dentist drill. Other people have visual sensitivity. They cannot tolerate the flicker of fluorescent lights. They're going to have to be gotten away from fluorescent lights unless we get the new electronic ones that work at a higher frequency. Touch sensitivity. I can't stand scratchy clothes against my skin. In fact, I find that certain types of t-shirts are rough fabric. I can't wear those t-shirts. These are very real things, and they can be very debilitating. And these sensory issues need to be researched. They are also something that's going to need to be accommodated.
So we know that hypersensitivities, so increased responses to certain sensory stimuli, is common in autism, as are hyposensitivities, so reduced sensory responses to certain stimuli. And then in this slide and the next is an example of a task called a task of global local processing. And so in this image, you see a heart, so a heart shape made out of stars. So there's kind of the bigger picture view of this, which is the heart, and also a view of the components or details, which is the stars, and balancing those two. Here you see an M made out of T's. And again, seeing the bigger picture tends to involve longer range brain networks, especially between the prefrontal cortex and other parts of the brain. And then the processing of the details or the components or the parts tends to be more reliant on short-range connections, or what's called local processing. So global processing for the big picture, and then local processing for the details and the components. And in autism, there tends to be a strength for local processing. So processing of the details, the parts, the components, those tend to draw more attention and tend to be more salient to the individual. And one of the really interesting consequences of that altered brain connectivity is that it can be more difficult to recognize people by their faces. So difficulty recognizing people by their faces is sometimes called face blindness. In neurology, it's called prosopagnosia. And it requires processing of a lot of different components and then taking in the whole. So looking at the gestalt or the overall, the big picture, rather than just the components individually and separate. And prosopagnosia, so difficulty recognizing people by their faces, is present in about 1% of the general population, but is present in an estimated 30% or more of autistic individuals. And so it's really one interesting example of how the underlying neurology can influence brain function and developmental skills. Okay. I want to say a little bit too about this cognitive difference in autism, which is more difficulty with cognitive control. Cognitive control is a capacity of the brain where it resides very much within the frontal parts of the brain, especially the prefrontal cortex. And cognitive control is an ability of the mind to override impulses, to make decisions based on context, to strategize, to problem solve. So cognitive control is sort of considered one aspect of executive function. Its component parts are initiating or starting a movement or a thought, inhibiting, switching or transitioning, and sustaining. So these four key components of cognitive control are needed for motor acts as well as cognitive acts, so for movements and thoughts. And we know cognitive control is more difficult in autism. And we've actually done some research. We've been part of a series of clinical trials looking at some very novel software platforms, which are really, they're sort of designed to be experienced like video games, but they're designed in a way that builds a person's cognitive control capacity. So we've conducted some clinical trials. This was in partnership with UCSF and led to the first FDA-approved kind of device therapy for improving cognitive control in children, children with autism, children with ADHD. And a really interesting part of this research is that it showed improvements not just in attention and executive function, but actually improvements in EEG, so electroencephalography. So the brain's electrical patterns of firing also improved as part of this. And so this is actually, this particular tool is called Endeavor RX, and it can be prescribed by physicians to help enhance cognitive control in children. Okay, I'm going to skip through this. And finally, just talk a little bit about the motor differences in autism. So motor skills we know can be kind of categorized as gross motor, so large scale movements of the arms, legs, and torso, and fine motor movements, which are the refined movements of the fingers, lips, tongue, and eyes. And there are some well-known motor differences in autism. One is difficulties planning and executing sequences of movements, and this is referred to as dyspraxia or apraxia. Very, very common in autism. Another is fixed stereotyped repetitive movements or behaviors. This is actually one of the core features of autism. What's very interesting is that these behaviors are considered semi-voluntary, meaning that they are to some degree within a person's control, but not entirely. And they might occur outside of a person's awareness, and that they might assist with reducing anxiety. So they might actually serve a purpose and have a function for the individual. And so some of these motor differences are really important for us to understand because they can influence a person's behavior, and then they can improve with support of the motor system. So motor-based therapies, for example, but also different types of sensory supports to the motor system, different ways of prompting and helping with carrying out sequenced movements. Okay, so we know there are genetic and environmental factors that influence brain development that then lead to differences in brain function. And these can influence the health of the rest of the body. At the same time, differences in the body can be a result of genetic and environmental factors and can then also go back and influence brain function. So this is there's really multi-directionality in this flow diagram, but I'll spend a moment now to talk about some of the differences in the body. And so the gastrointestinal system is probably the one where differences in autism are most common. And there are research studies that estimate somewhere around 80 to 90% of autistic individuals have some type of gastrointestinal symptom or condition. Some of the most common ones are chronic constipation or constipation that fluctuates with diarrhea, abdominal pain, gastroesophageal reflux, inflammatory conditions of the bowel, and alterations of the gut microbiota. So the microorganisms that inhabit the gut are actually research studies have found for some individuals are very different. And one finding has been a reduced diversity of the gut microbiota. There's a lot of research now looking at the gut-brain axis, so the way that gut health and the gut microbiota influence brain health. And we've actually had some research, been part of some research studies looking at novel therapeutics, some medications that target gut health that look very promising for helping to improve autistic symptoms. And there are a lot of metabolic differences that are part of autism. One in particular that's an area of my specialization is mitochondrial dysfunction. Mitochondria are tiny structures inside of cells of the body. One of the important functions of mitochondria is to generate ATP, which is sort of like the currency of fuel, or the energy currency of the cell. Helps to fuel all of the body's functions. It's an energy source. And some of the research that I was part of at Columbia University using brain imaging showed patterns of mitochondrial dysfunction directly in brain tissue in a subset of autistic individuals. And there are ways to support mitochondrial function through dietary changes and nutritional supplementation and some lifestyle changes too. And this is a part of our medical program at Cortica. And then finally, there are differences in the autonomic nervous system. And so here you see the two branches of the autonomic nervous system, the sympathetic and the parasympathetic. The sympathetic, when activated, puts us into a state of fight or flight, so a stress response, whereas the parasympathetic system, when activated, helps to put us in a state of rest and digest or relaxation. And in autism, a lot of research has now shown that there's an imbalance between the sympathetic and parasympathetic nervous systems, with sympathetic overactivation and parasympathetic underactivation. But there are ways to help modulate that. And one of them is a device therapy called cranial electrotherapy stimulation. It involves applying electrodes to the ears, and the electrodes provide a tiny microcurrent that stimulates different nerves that then travel to the brain. And this can help to reduce some of the symptoms that can come with the chronic stress response. Okay. This is just, before I go into the client vignette, I just want to show you this child development framework, or we call it sometimes our neurodevelopment tree. But it's a way that we can kind of bring together all of the different components that are so important for whole child care and try to make it more accessible and understandable, because it's a lot to know for professionals, but certainly for caregivers. And it can be daunting and overwhelming. And so this framework helps to show really how everything comes together. And when I review it with the families that I work with, I like to start at the bottom and talk about how the strong roots of a child's development resides in their experiences at home. So their relationships with family members and those interactions, and also their experiences in the community and in school. So all of that deserves a lot of our attention and thought. And then the trunk of the tree represents the health of brain and body. And there's so much for us to better understand it and therefore support in a child's genetics, their metabolic function, the electrical activity of their brain, whether they might be experiencing seizures, which we know are very common and happening in about an estimated 15 to 25% of autistic individuals. Sleep disturbance is present in about 80%. GI conditions, immune differences, and then attention to nutrition, exercise, and stress reduction. All of that is so essential for a whole child care program. And then if we look at the branches of the tree, that's where we're thinking about brain network formation and how we can apply developmental and behavioral therapies to help support brain network development. Farther up on the branches, we're thinking about creating experiences in athletics, music, and arts for all children, as well as academic and vocational studies. Those can be tailored, and those are valuable experiences that really are accessible to all children. And we're thinking about physical and mental health lifelong, not just current, because we know that if we're thinking about fostering lifelong physical and mental health, we really want to be trying to nurture a child's unique developmental trajectory and not trying to impose neurotypical or neuronormative standards. That can lead to masking and camouflaging, where an individual is trying to act in neurotypical ways that may be unnatural for them and for the way their brain works. And that has consequences of anxiety and depression, and so long-term negative mental health consequences. So we're thinking about supporting an individual's physical and mental health for the long term. And then up above are kind of the four main areas of kind of life goals that really all people share: self-care skills, relationships, recreation, and then contribution. So a way to have a sense of meaning and purpose, and a way to make a contribution to one's community and society. And then the top is joy, which we represent as the sun, to remind us that all of this is for the purpose of creating experiences of joy. And at the same time, it's those experiences of joy that nurture the growth of the entire tree. And so those types of joyful experiences should be a part of a child's everyday. I'll just take a couple minutes to show a very brief client vignette, and then I'd be happy to answer any questions. Actually, I'm going to pull up the vignette. So as I'm doing that, please feel free to unmute or enter any questions in the chat. It's just taking 1 second to pull up.
Hi, I'm Luke. I put a question in the Q&A section.
Yes.
Yeah, I was just curious, just like within your career, but also at Cortica, what you were doing, in terms of, we talk about, boys being diagnosed, right, with autism, and then doctors often overlooking when girls have potential signs for autism, but they don't necessarily look for it, like in this like patriarchal or historically patriarchal system. So I was just curious what you guys are up to, like nowadays, in terms of combating that and increasing education and all of that.
It's such a great point. We now know, for a long time it was thought that the ratio of boys to girls for an autism diagnosis was 4-to-1. We now know that was probably a reflection of kind of a bias, in our assessment tools, which have been designed to really detect the way autism shows up in boys more so than the way it shows up in girls. And the features in boys tend to be a little bit more outward, with more sort of repetitive behaviors that are more noticeable. And in boys, there also tends to be more of a language delay that is likely to prompt earlier evaluation and attention. In girls, there tends to be a higher level of language, and the autism symptoms tend to be ones that are more internal or inward, where there's less of maybe outward repetitive behaviors, less hyperactivity and that sort of thing. There also does tend to be more masking and camouflaging in girls, and the development of kind of coping techniques to be able to manage social environments. They're also often kind of labeled as shy, rather than kind of investigating further to see what the underlying root or source of that might be. So given that standardized tools are still quite limited, how do you approach appropriate diagnosis and then support for girls? I mean, it starts with just an awareness and of the way that autism tends to manifest in girls. Fortunately, there is a lot more research now about that. And a very, very valuable resource is firsthand accounts. So there are just wonderful books that have been written by autistic women about their experiences in childhood and in adulthood. And so I think that's a really valuable resource for individuals themselves, for caregivers, and also for professionals.
Thank you.
Yeah, thanks for the question. So I just have a couple of slides about a child that I had worked with that illustrates how kind of all these different components come together, and especially the importance of the medical evaluation, which still today, unfortunately, is very often delayed. So when children get an autism diagnosis, very often it's a developmental or psychological assessment. And then they're immediately referred to things like occupational therapy, speech language therapy, or behavior therapy. And the medical evaluation is often delayed for months or years. And often I see children who are in their teens or young adults who've never had the appropriate medical evaluation. So this was a boy who had speech language delay and some repetitive behaviors noted around 18 months of age, and then was then diagnosed with autism at 2.5 by a psychologist at a developmental clinic at a local children's hospital. Some of his notable features at the time, I saw him when he was soon after he was diagnosed. His head circumference was in the 95th percentile. We know that is common. So macrocephaly is a very common early feature that comes with autism. He had no words and no word approximations. He did follow some simple one-step commands. On his motor exam, he walked on his toes, which is a common sign of differences in sensory processing. He had low muscle tone or hypotonia, and he had moderate fine and gross motor delays. So he had some of those motor features that come with autism. And he had repetitive self-stimulatory behaviors, including hand flapping and visual stims. So he liked to use his vision in some interesting ways, and he would use his fingers and hands to kind of stimulate his own visual perception. So one of the first tests I did, which is a test that should really be done on every child at the time of diagnosis with autism, is a 24-hour ambulatory EEG. So a routine EEG can be done. That's a 20 to 40-minute study. A lengthier study provides more information. So sometimes we'll do a 24-hour recording of electrical activity in the brain. And this is a image of what his EEG looked like. Now, if you don't read EEGs, it's hard to know what this means, but below is what a normal EEG looks like. So what his EEG showed was that he was having continuous seizures during about 60% of the time that he was asleep. So there were no outward signs. If you looked at him while he was sleeping, he looked like he was sleeping. But with the EEG recording, we were able to see that he was having a lot of seizures at night at a time when development, and brain networks are supposed to be consolidating. That was being interrupted by seizure activity. We also, at the same time, did a genetic test called a chromosomal microarray analysis. And his showed that he actually had an extra copy of the Y chromosome. So his genetics showed 47 XYY rather than what would be typical for males, which is 46XY. And what's interesting about the Y chromosome is that there is a gene for a neuroligand, which is important for brain development. So it helps to support the formation of brain networks. And so we had a lot of medical information about him, about his genetics, about his brain's electrical function. And immediately we started seizure medications. Ultimately, steroid treatment was what allowed us his seizures to stop. He also was initiated on a diet called the low glycemic index diet that is a treatment. It's a known treatment for seizures. The ketogenic diet is another known treatment for seizures. The low glycemic index diet is easier to implement than the ketogenic diet. And he responded extremely well to those medical therapies and had resolution of his seizures. He also received appropriate therapies to support his brain development, so occupational therapy to work on sensory processing, fine motor skills, physical therapy to work on gross motor skills and strength, endurance, speech language therapy for language development, music therapy, which is a very interesting approach that actually supports all domains of brain development, so sensory, motor, cognitive, language, social, and emotional, by using the tools of music, like rhythm and intonation. He received ABA, so behavior therapy, which really focused on building his daily living skills, and helped support him so that he could navigate community settings well. And then also family counseling to support the mental health of his family members. And then by the time he was 6, he actually no longer qualified for these services. So his development had progressed to such an extent that he no longer required those supports. And at age 6, he no longer met diagnostic criteria for autism. And at that point, he was also off all medications and able to be in a mainstream first grade classroom in a private school. So our hope is, and the purpose of designing whole child care clinics for autism is so that more and more children can receive the appropriate medical, behavioral, developmental, and mental health support to be able to have these kinds of outcomes. Okay. I'd be happy to take any more questions. I know we're kind of at the hour, but I'm happy to stay on for a little bit longer.
Can I
Just
ask
feel free to unmute. Yeah.
Okay, thank you. About the EEG 24-hour study, is that the way you observe the default model of children with autism? And I'm curious because our lab does that for kids with depression, and we will find that they will have seizures in this part of the brain, in the prefrontal cortex, or the linkage and the network are often problematic. So I'm curious because in a lab we have to like delete the noise of like when the eyes blink there have noises, and it's impressive that you can do 24 hours because we only do like 1 hour per, and we're like this one. And how do you record a 24-hour?
So for most children, we begin with a 20 to 40 minute EEG. So more similar to what you're doing. And that information plus the medical history informs whether or not we think we need a longer study. So if we think that there's concern for, of course, if there's concern for seizures during sleep, that would warrant potentially doing an overnight study. But we also take steps to try to help children sleep during a shorter 20 to 40 minute boarding. So they come to the clinic, we've sleep deprived them the previous night at home, and they come in and often they'll nap and sleep during the clinic. So sometimes all that's needed is a shorter study. But the way to do these longer studies of a day or sometimes multiple days at home is you just need the equipment and you need the appropriate setup. So clinically, it is something that's done quite often in the pediatric neurology population.
Thank you.
Yeah, thank you. Oh, Pat, go ahead.
Hi. Well, first of all, thank you so much for this workshop. I have a question. So one of the main challenges I have when dealing with family with autistic children is that so I'm from Bangkok, Thailand, and I own and run a school here, and we accept special needs children. The thing is like in Thailand and I think in a lot of Asian countries, autism or any special needs is like a stigma. Like, so parents or grandparents, especially those who live in extended family, would kind of deny it. They don't even want to hear the word autism. So the problem is that because of how the kids are, it's really difficult to go to a mainstream school. And they need to find a school that can accommodate the kids. And what's usually happening is that the mothers understand and accept how her child is, but the father is usually the problem. So the father is the breadwinner, right? He would make money because of how the child is, and the mom has to take care of the child maybe 24/7. But because of how like maybe the dad doesn't understand, doesn't want to accept it, it actually leads to some kind of also like violence like at household, like, like, okay, like he come back home and then the child doesn't behave, he blames the mother, and then like there could be some sort of violence happening that like, like, or like it would lead to the father who just like leave the home, or I don't know, like just like comes here, like spend time like not as much as possible. So this part of it is actually causing a lot of trouble for the mother. That's my first question. And my second question is that a lot of parents, like I feel like maybe they think that autism can be treated. So like once the kids are in my school and then I provide like therapy with psychologists, with the music program and something like that. And the kids actually like got better, right? Because like, oh, this is like the kind of care that the kids need. And and then the parents mistake that like, oh, now my kids got better. I'm gonna like bring my kids to a mainstream school. Because like now he got fixed or got treated, like, yeah. So these
Yeah.
are the two challenges that I have met. Yeah.
Yeah. I mean, and that's why family support, you know, the approach that we use, I describe it as being family centered, because what you're describing are experiences within families that are actually quite common. And so to best support a child, we need to support the whole family. And that means understanding the experiences of caregivers. I think it really begins with helping to build an understanding of autism, very much like what I've described to you today. If you start, I think a lot of the challenges that family members may have, especially conflicts that might come up between different family members, is because they have different understandings of what autism is. And I think there's been so much research now that I think we can arrive at a common understanding, and one that's very positive in the sense that based from that understanding, which is very neurologically based, research based, from that common understanding, we can then agree on the steps to take. And then it is very important for families to have access to those supports, right? It's very hard to, it's much more likely that a resistant family member will be able to change in their own views if they recognize that in doing so, by accepting the diagnosis and taking steps, they'll make things better for the child's quality of life and future. So there's no easy single answer, but I think we know enough now that we can meet families wherever they're at with whatever understanding they currently have, and educate and change and support. So I believe every family can be supported onto a better, a more positive, more life-affirming path. But cultural differences are certainly important to take into account and to understand and to be very sensitive to. So I hope that, part of the reason I wrote Magnificent Minds was because I wanted families to be able to access what I thought was the most important information, but in a very understandable, easy to read way. Because so much of information about autism is not understandable at all, and I've also seen a lot of families kind of go down like the rabbit hole where they're trying to do the research on their own. And it's just extremely hard to understand. There have been thousands of genetic research studies of autism, thousands. And most of them are hard for me to understand, And so I see parents thinking that it's their responsibility and thinking that to do the best for their child, they need to go down that rabbit hole. And so, I think it's just so important that we make resources really understandable and accessible. Thank you, Pat, for your question. Maybe we'll go to Nikki next. Nikki, would you like to ask your question?
Oh, yeah, I'm sorry. I lost connection there for a
That's
second.
okay.
So I'm really interested in like I want to know how much research have you done on the adult population to kind of gain some of these conclusions, because I work with that adult population. I am an adult with autism and I wasn't diagnosed until 28 because I basically spent my life masking and just trying to fit in with all the neurotypical individuals I went to school with, which was very, very challenging for me. And so behavioral outbursts were pretty common for me. And so they misdiagnosed me numerous times with so many different conditions that it was just like, okay, really? Like, that doesn't make sense for me when I would read up on it, because I was also one of the higher intelligence with the spectrum, which I've noticed that girls tend to be either higher functioning or extremely low functioning. It's one or the other, in just my personal experience with the adult population. And so I kind of wanted to know, because I've done a lot of research on the adult population, and a lot of what you're saying, we don't see much in the adult population, and their window of ability is so shrunk that there's barely room to teach them new skills at this point in life. And the burnout rate is extremely high, like what Pat was mentioning, and like families are becoming extremely troubled, and there's even been homicides in some of these families because of the stress. So sorry, anyway, that's what I want to know is, like, what are you looking at in the adult population?
Yeah. I mean, I think if there's a population that's even more underserved than neurodivergent children, it's neurodivergent adults. And that's a societal problem, a failure on the part of our society. I'm a pediatric neurologist, so my focus is on the pediatric population, but at Cortica, we serve new clients from birth through 18, but once they're with us, we continue to serve them. So we serve a lot of adults in their 20s and 30s, some in their 40s. And often it's because there are not appropriate places to refer them to. And we find that our knowledge base still allows us to be really, the best able to serve their needs. My own individual research, so some of the metabolic mitochondrial research I mentioned was in children and adults. So I think a lot of those medical biological factors are really common in children and adults. Recently I gave a webinar on the transition to adulthood for a group called Autism. It was a conference called Autism Parenting Summit. And really, as I was designing that presentation, I was really thinking about, what is common between children and adults, what's different. And this idea of a transition, it's so interesting because often it's felt by families to be like a very discrete event, because all of the services fall off, including school, and often insurance coverage of services stops at like 18 or 21. And so it feels like the transition is a discrete event, but really the transition is happening, that change is happening continuously, year after year after year. And so this idea of like a sudden transition to adulthood, that's a construct by our institutions, the way we set things up. And it is not helpful at all.
I totally agree with you on that. The service gap is where, like, I like that you mentioned that, because that is a big problem right now. But yes, I agree with you 100% on everything you're saying. And I would be interested in seeing the research you did on the mitochondria differences in adults as well, because that's something that really interests me as well.
Yeah, I'll send the link to Kimia so she can share it with the group.
Thank you so much. What a great answer. I really appreciate that.
I guess we'll wrap up, Kimia, with just one more question, if you'd like to ask us.
Yes, thank you so much. First of all, thank you so much for being here. It's such an honor to have you. You're incredible. But my question for you was, because I was actually giving a presentation on autism, and because we have a huge global audience, they brought up the situation with stigma in a lot of the countries, to the point that even the doctors are hesitating to diagnose the patients. And it's like parents are ashamed of having a child that has autism. And especially after reading your book, I really love that you have a positive focus and strength-based. So I think a lot of people see it in a negative way. And the way you break it down in your book is wonderful, because I think you approach it holistically and very strength-based instead of looking at all the issues. But other than that, like, how can we help, especially in countries that is such a huge stigma? How can we break this? How can we help? How can we advocate better and educate better so they're willing to listen?
Well, I think this is the reason for the neurodiversity movement, and the neurodiversity movement is a social justice movement. It's fairly new, so it needs our support. That's, I think, one. And it's still very, I think it's as new as it is in the US, I think it's even newer to a lot of other countries. That's one. And I think, and it's one of the things I write about in Magnificent Minds, is that the deficit-oriented, problem-centered view, which is so like, it's just so pervasive in the field of neurodevelopment, it is neither accurate nor helpful. It does not serve us at all. And it's a reflection of negativity bias. So it's the reflection of a bias to focus in on the negatives when it comes to neurodevelopmental, neurological differences. And, you know, a strengths-based view means finding strengths because they're there, and finding the intelligences because they're there, and the gifts. And there are just now countless examples of individuals with incredible autistic types of intelligence, gifts, and these are sometimes called special isolated skills. In the past, they've been called savant skills. Some people, researchers have estimated the present maybe in 10% of autistic individuals, but some research studies show that they're maybe as high as 80% have some type of this specialized skill. It can look a lot of different ways, but if you can identify it and expand on it, often it's also an area of passion. And so we need more and more of these stories to be highlighted, and for people to begin to see and take interest in how unique and extraordinary a lot of these things are. There's a wonderful documentary film called The Speed Cubers that features Max Park, who is an autistic young man who has won multiple world records, set multiple world records, and won championships in speed cubing. And he had very delayed language. He was diagnosed with moderate to severe autism. He started using a Rubik's Cube because he had severe delays in his fine motor skills. And look at how delayed fine motor skills can be transformed into a skill that exceeds, that is kind of world record breaking, So it just, neurodivergence challenges us to really think differently. I know it takes time. I know it takes a lot of conversations, a lot of research, a lot of just trying to make this information more understandable, more accessible, and just have it reach more audiences, I think. Yeah. So
Thank you so much.
Thank you. So great to be with all of you. Just appreciate your interest in this topic and appreciate you joining today. So best of luck to all of you in the wonderful career and educational pursuits that you're undertaking.